Clemens, and good morning from New York, dear colleagues, and a warm welcome to this online meeting on addressing structural barriers. Thank you very much for the invitation. My name is Boyan Konstantinov, and I work at UNDP at the HIV Health and Development Group, working on policy issues related to key populations. And as you know, or as you might not know, UNDP is co-convening the work on law and policy reform under the joint program, the Joint UN Program on HIV and AIDS, UNAIDS, and together with UNFPA and UNODC, we also co-convene the efforts to increase access of key populations to HIV services with a strong focus on prevention. Why are we here? We are here because we have a serious problem when it comes to legal and structural barriers and key populations and people living with HIV that impact the HIV response worldwide. According to UNAIDS, as you all know, 65% of the global new infections are among key populations and their sexual partners, and outside of sub-Saharan Africa, this percentage is as high as 90%. There's also a worrying phenomenon that while getting older, meaning that HIV positive people on treatment live longer, the epidemic is also getting younger, which means that ever younger people, particularly young people from the key populations, are contracting HIV. And we also know that the COVID-19 pandemic disproportionately impacted key populations and in many cases created further and greater barriers to accessing services. But there are also examples how rights-based and evidence-based approaches worked. Putting trust into communities actually helped overcome such barriers, such as alternatives to imprisonment, distribution of greater quantities of ARVs, PrEP, methadone, and overall greater community engagement in service provision. You all have read, I presume, the Global AIDS strategy, and you know that it identifies as a priority action the removing of discriminatory and punitive laws, policies, and structural barriers in the areas of HIV transmission, exposure, barriers to treatment of key population, laws criminalizing key populations, gender, also covering adolescents and young people. And this is also the request of the two UN member states and UNAIDS of the 2021 Political Declaration on HIV and AIDS. Unfortunately, we still have, despite some progress, a lot of work that we need to do in order to overcome these legal and structural barriers. There are 73 jurisdictions, according to HIV Justice Worldwide, that still explicitly criminalize HIV, transmission, exposure, and non-disclosure. And in many other countries, general laws were used to target people living with HIV for alleged transmission, exposure, and non-disclosure. Despite some improvements and some recent improvements, consensual same-sex between adults remain criminalized in about 70 jurisdictions worldwide. 2021 was sadly the deadliest year on record for transgender people, with over 375 trans people murdered, according to a recent report of Forbes. We can say, and we have to say, that there has actually been a regress in countering structural barriers that prevent sex workers from accessing HIV services. There is a spread of punitive policies, end-user models, online policing, shutting down of virtual opportunities to negotiate safer sex and driving sex work further underground. And the international community, which means us, we must also be more proactive in engaging on human rights of sex workers. People who inject drugs are around 28 times more likely to be living with HIV than the general population. And according to UNODC, every 4 minutes, someone contracts HIV through unsafe injecting equipment. And yet, we have structural barriers that prevent people who use drugs from accessing HIV prevention, and in many cases, they are combined with other punitive measures. People in prison are over seven times more likely to be living with HIV than adults in the general population, and yet few countries implement comprehensive HIV programs in prison, and many fail to link their prison programs to the national AIDS programs, which also cover key populations. A little bit more than 20 countries worldwide provide comprehensive social protection that is tailored to key population. So there is undoubtedly a need to speed up and also scale up our work on addressing legal and structural barriers among key populations. I would like to show a few slides, and colleagues, if you could please show the slide deck. The independent commission, the Global Commission on HIV and the Law, which was convened by UNDP on request of the joint program of UNAIDS, has provided a lot of evidence, a lot of first-hand evidence on the nexus between inadequate punitive norms and policies and problem with HIV responses, and also a lot of examples of enabling legislation, of enabling policies and practices that actually catalyze adequate rights-based, evidence-driven responses that address the needs of key population, and has provided also concrete recommendations for improvement. This process has been going on for quite some time. The first report was issued in 2012, and it was then supplemented with an update 6 years later in 2018. On these slides that I would like to share, you see some of the conclusions of the Global Commission. Colleagues, here you see how the process was organized. May I have the next slide, please? Yes, so here you see the key findings of the Global Commission that are relevant to the current global priorities as spelled out in the Global AIDS Strategy and the high-level political declaration. First priority is the nothing about us without us, the civil society engagement, the community engagement, which is a guarantee for evidence-informed and right-based responses with meaningful engagement of communities who are actually impacted by these responses. Access to justice, which is absolutely relevant when we're discussing structural barriers, and absolutely relevant to the lived experiences of people living with HIV and representatives of key populations. And then last but not least, a very important issue of decriminalization of HIV, where unfortunately the progress still globally is very slow, and it needs to speed up significantly if we want to deliver on the Global AIDS Strategy. Next slide, please. And here you can see a little bit on the legacy of the Global Commission on HIV and the Law. And I'm going to share the link to the Commission website to those of you who were not familiar with the conclusions and recommendations of the Commission to familiarize yourself. A follow-up work has been going on in over 90 countries worldwide, and this is not only an effort of UNDP. It's not even only an effort of UNAIDS, of the joint program. It's a comprehensive effort of all stakeholders, including communities, including civil society organizations, human rights defenders, and of course, governments who would like to see an improvement in their national HIV responses. So you see that we have quite a good toolbox. We have quite a good constituents of stakeholders, and we have abundance of evidence that shows the way on how to improve HIV responses, and this is very important. So on that note, I would like to conclude, wish all of us a productive meeting. We have a lot that we can work with, and our discussion is going to focus, I'm sure, also among many other topics, on how we can operationalize what we already have in order to speed up and scale up our responses and ensure that people living with HIV and key populations have access to services. Thank you very much for your attention, and let us start the meeting.
Thank you so much, Boyan, for these great opening remarks. We'll now move to the next and the first overview presentation of this meeting provided by our colleagues from the UNAIDS human rights and legal teams, and working together with actually Fariba Soltani from UNODC, introducing specifically addressing legal and structural barriers in the context of people who inject drugs. So over to you, Simone, for the first part of the overview, and then Fariba.
Thank you, Clemens, and good afternoon, everyone. Really happy to be with you. Next slide, please. I want to jump straight into the presentation. So I'm not going to be speaking to these because already Boyan had said that barriers continue to impede KP's access, and these are just examples of what these barriers are. Next, please. Criminalization, again, a major obstacle, and we cannot express enough how important all the partners need to be working together to address the overuse of these criminal laws as we also work towards removing them, especially when COVID, and we have seen how much this has been affecting a key population in accessing temporary social protection and other prevention examples of services. Next, please. Opportunities and momentum are there, and again, this year has been really phenomenal in so many areas, and particularly when it comes to societal enablers, with the political declaration that's putting equality as at the heart of the response. And even when we're speaking about community-led responses, it's giving a lot of emphasis on these community-led responses vis-a-vis the 2016 declaration. We have a global AIDS strategy that is anchoring the HIV response in the principles of human rights and equality, and of course, in the resolution on human rights, and all of them together are going to be giving a voice to the communities and also commitments to the country to deliver. Next, please. The 2020, next, please. So the 2025 targets are extremely, of course, important, but for the first time, we have these societal enabler targets. And why they are critical, next please. We will see that this is the cost of inaction, or the cost of not addressing only the service targets. If we do not go and make sure that we address these societal enablers, the human cost would be high. So with the targets, the 10-10-10 targets, we would be able to avert 2.5 million new infections and 1.7 AIDS-related deaths between 2020 and 2030. Next, please. How we want to do this. So I'm going to give you a few examples of what we are already working with. It could be excellent to promote and scale up. So bringing it all together from global to national, I want to highlight here the Global Partnership for Action on Stigma and Discrimination, which is one of the key barriers that we have been speaking to. And the commitment to date of 29 countries signing off to this global partnership, and understanding that these countries, when they commit because of the high-level meeting and many examples of success. The co-conveners of this global partnership are UNDP, UN Women, UNAIDS, Global Fund, GNP+, and other partners who are working within the technical working group. So it's really important to highlight how this is bringing everybody together. Next slide, please. What is also important about this global partnership is the community efforts. So it's the leadership of the communities, as well as we all know what works. So it's putting all our technical capacities, our knowledge, the know-how into the evidence that has been provided, the evidence for eliminating HIV-related stigma and discrimination across the 6 settings, as well as a guidance that we're working on monitoring and evaluation. And of course, again, the catalytic synergies and linkages between all the donors and the partners, including PEPFAR and CDC. Next, please. I'm going to skip the next 2 slides. Thank you. The other one again. And these will be shared in the chat. I'll be putting some good links to the advocacy campaigns that have been held within the global partnership efforts. So what works and needs to be continued? Of course, all of us agree that decriminalization has to be the end of the road for all of us and all our efforts. But again, we do have different synergies, different diverse communities, and of course, countries that have different levels of discrimination, different levels of challenges and conservative settings. So here it's a lot of diverse interventions that are going from working on awareness raising to removing legal barriers. So training and capacity building of service providers, important to highlight how this is for both the service providers as well as the community. Speaking about, again, legal literacy is very important. So Uganda, we have the dialogues with health workers, the training of emergency workers in Iran, and the sensitization of legal service providers in Central African Republic. Convening and advocacy is great because it shows how the communities, when coming together, they could be very supportive. And in that, it's the community speaking to the partners at the national level, all stakeholders in one table. Next, please. The accountability for HIV human rights violations, most of these mechanisms are in place in many countries, but I'll just highlighting a few, like the National Human Rights Institute in Jamaica, the Thailand National Code of Conduct on HIV Prevention and Management, and of course the humanitarian context in Peru and how this has been addressed. The Tracking Act cases of violence and also responding to human rights crises. We've been seeing so much happening with emergency support funding and support to countries, especially when it comes to the anti-LGBTQ bills that are being passed here and there. However, I think what needs also to be considered here, how to be proactive and put mechanisms in place to mitigate these before they arise. Then we have the advocacy based on data, and most of these tools are great and important, but we also need to go beyond the acquisition of these tools towards the implementation of the recommendation. Next, please. Then the guidelines and quality assurance, which again, all of the partners are involved in working. Most of the partners have reviewed their strategies, but for Global Fund, CDC, all of those have reviewed strategies this year, and it's important to note that all of them have highlighted the importance of gender and human rights and meeting the targets. So integrating these efforts into the funding models are critically important. Policy reforms to enable KP access to services. We see updates in many of the countries that we have in South Africa, the law enforcement, pledge not to confiscate condoms and harm reduction paraphernalia. Central African Republic, this is new, the quality of care and patients charter that's leading to non-discrimination in service delivery, and which proved also a good platform for reporting abuse and training of partners and healthcare workers. Next, please. Then the law reforms, which are really the parliamentary process and strategic litigation, which we all are working towards, whether they are broad non-discrimination provision like Iran adopting the anti-discrimination bylaw of healthcare settings, or population-specific provisions as in Angola, Gabon, removing provisions criminalizing same-sex relations. Same for the legal protection transgender persons in Pakistan and the mix of litigation in India and parliamentary process in India. And again, finally, the recent Botswana strategic litigation that in effect says criminalizing LGBT persons are a violation of human rights and the rights to privacy, equality, and non-discrimination. Next, please. And final is I want to bring here the tools that have been critical to the process and critical to the prevention efforts we are all working towards, and that's the Fast Track and human rights guidelines with all the checklists put in place here to say that without looking into these checklists, we will not be able to reach the targets when we are putting together our programs on prevention. Next, please. These are the additional tools, and I'm going to be putting in the chat most of these links to these tools. And thank you so much. And I give the floor now to my friend Fariba from UNODC. Thank you so much. Over to you, Fariba.
Thank you very much, my dear Simone, and thank you to Clemens and also to Boyan for setting the scene. So I think most of the structural barriers to address, regarding reaching HIV services for the key populations, they have been addressed. So I'm not going to go into those. I am going to talk about more the tools that we have and how we can go forward. My name, by the way, I forgot to introduce myself because I feel we have to rush to really get all the fantastic presentations that are waiting for us in this session. I'm Fariba Soltani. I'm the chief of the HIV/AIDS section for UNODC here in Vienna. And as UNODC, we are the lead agency within the UN Joint Program on addressing HIV amongst people who use drugs and people in prison settings. So this is what our mandated area is. So can you go to the next slide, please? Thank you. So as was mentioned by Simone and also by Boyan, there are global commitments that have been made through the Global AIDS strategy and also the political declaration. In addition to those, we also have the UNODC strategy, which was also adopted in 2020. We also have previous commitments that have been made in the past years, which still stand and guide our work. One is the outcome document, which you see here. Of course, the Nelson Mandela rules, the United Nations standard minimum rules for the treatment of prisoners, the Bangkok rules, which you don't see here. And also we have 2 United Nations system common positions. One is on drugs and one is on incarceration. And these are very, very important tools for the work going forward when you're addressing prisons and also addressing HIV among people who use drugs. They give us the UN joint vision on what we want to do in order to make sure that the countries are rethinking the way they are over-relying on incarceration and putting people in prisons, both as in reducing prison overcrowding and all the problems that Boyan was also referring to within the prison system, and also not the problems that it causes for people who use drugs to access services, because they are afraid to approach services. And so next slide, please. So this is what we do. And one thing that is very important, I think, in the way forward on working on these issues is building partnerships. Here you see a few photos of what we are doing actually at country level, because we have a very small team in Vienna, but the work has to be done at country level. And you see that we need to build partnerships with our civil society and community partners. This is the most important part of our work. I will speak to it a little bit later as well. But also with the law enforcement, with the narcotics control people, with parliamentarians, with the service providers. It is so important to have all this group who, whether they're creating barriers or they all have a say in what is happening at country level when you're looking into how to address HIV and now COVID for people who use drugs and people in prison. So building these partnerships and having them around the table is very essential. Next one, please. We, as colleagues have mentioned, we have many tools and we know what works. So really there is no excuse in not getting the services and the good programming on the ground. So we have generated a lot of good tools, and most of these tools have been produced in close collaboration. I mean, going hand in hand with our communities, with our civil society partners, and of course our UN sisters here. So we have generated the information, and this is what we're doing, disseminating it at country level to inform policy and programming, which is a very important part of the work. Next slide, please. I can't say enough about advocacy. It is very, very important for us as a community of people who are really like-minded and want to address the situation and increase accesses to services for people who use drugs, to continue with the same voice on our advocacy efforts. And a couple of examples that I have here is the result of the advocacy that we have been doing. For example, in Vietnam, as a result of the COVID, actually, multi-dose dispensing of opioid agonist treatment was approved by the Ministry of Justice in 2020. In Egypt and Pakistan, we have been working for many years to start the implementation of opioid agonist treatment, but this was not the case, but we got approvals in 2020. And of course, in prisons, to start OAT programs, in prisons is very important, and we managed to get it going in Kenya and Morocco. But this is the result of advocacy that we need to work together to make sure the messaging gets out there. Next slide, please. This is regarding policy reform. Again, this is something that we all work on, you know, working with parliamentarians. And here I'm not going to go into the details. We will share our presentations, just a few examples of where we have managed to work together with the national partners to do policy reform with regards to the drug control strategies, which are more human rights-based, gender-sensitive, and evidence-based, according, you know, so that they do implement what works. As I say, we have the evidence. It just needs to be rolled out and implemented at country level. Next, please. And something that is very, very important for our program here at UNODC is working with our communities. We have had a very, we've got two informal groups, one for prisons and HIV, and one more well-established one on drugs and HIV, whereby we work together. We have very close relationship. And I think this is the crux of the matter, to really have the community voice loud and clear to tell us what is the needs, and then working together to make sure we develop the tools together and to roll out the tools together at country level. And you can see some pictures of, we have a grants program, some of our partners at country level. We had a presentation from this group of our partners for the World AIDS Day, and they have done fantastic work during the past year with the funding that was provided, and we look forward to having more of this, because we really believe the communities should be leading these efforts and they should have a very strong voice. Next one, please. And this is just the last photo of our drugs and HIV group. In conclusion, just what works, as I mentioned, meaningful collaboration with communities, advocacy, I can't say enough about that, legal reform, capacity building, high quality data, which is essential to give us the evidence to provide justification for what we are promoting. And of course, strong partnership and having law enforcement, drug control, health authorities around the table to discuss, you know, what needs to be done at country level. And with that, I thank you, and I'm really looking forward to hearing the presentations. And back to you, Clemens. Thank you.
Thank you so much, Simone and Fariba. So we've had an overview here that introduced the new targets, including the new 10-10-10 targets on social enablers. And the member states actually have committed to these targets. We have guidance in place, and we know what works, as we have seen in this overview. We're now going to look into country perspectives, first sharing a government perspective to Manuel Cardoso from Portugal, looking into key population programming, specifically in Portugal, sharing a practical experience. Over to you, Manuel.
Obrigado, Clemens. Obrigado pelo convite para estar aqui com todos vós. Vou realmente tentar apresentar um pouco daquilo que foi a experiência portuguesa e pedia já o próximo slide, por favor. Aquilo que aconteceu em Portugal, o que vos trazia é que em 98, o próximo, por favor. Próximo slide. Exatamente. Aquilo que vos trazia era que pensar que em 98 o consumo de drogas ou o uso de drogas em Portugal era um dos principais problemas do país. Estimávamos que 1% da população consumia drogas e daqueles que estavam em tratamento, 98% eram mesmo consumidores problemáticos de heroína, e desses 48% consumia ou usava a droga por via injetável. De todas as infecções VIH, 56% eram em pessoas que usavam drogas. Naquele momento, o uso de drogas em Portugal era ainda crime. O próximo slide. O governo, nessa altura, propôs a criação ou a implementação de uma nova estratégia, e essa estratégia baseava-se em 2 princípios fundamentais: o do humanismo, que assumia que mesmo os utilizadores de droga deviam ser tratados como qualquer cidadão, e o pragmatismo, no sentido de fazermos tudo para ajudar esses cidadãos a terem, digamos, a aceder aos serviços que entretanto lhes eram proporcionados. Por outro lado, esta estratégia desenhava-se numa estrutura balanceada entre a oferta e a procura. E no âmbito da procura começávamos por tentar tratar todos aqueles que queriam tratar-se, que precisavam de tratamento. A prevenção, nesta intervenção integrada, é importante a integração social, a redução de riscos e minimização de danos. Esta estratégia de intervenção integrada culmina ou acaba por ser depois baseada num novo paradigma, que é a descriminalização do uso de drogas. Em 99, com esta estratégia, depois com a lei em 2000, o consumo, o uso e a posse de drogas em Portugal foi descriminalizado, o que nos permitiu, de uma forma muito mais ágil, poder intervir junto das pessoas que usavam drogas em todos os sentidos. O próximo slide, por favor. A ideia desta intervenção, e porque à data o consumo de drogas ou o uso de drogas era o principal problema dos portugueses, pelo menos assim manifestado pela comunidade, pela população portuguesa, fez com que, sendo um problema nacional, a solução ou a estratégia para resolver este problema era também uma estratégia de âmbito nacional que acolhe o trabalho e a informação de todas ou de muitas áreas ministeriais. Para além de um coordenador, nesta estrutura de coordenação, para além de um coordenador nacional, há um conselho interministerial que deve aprovar e implementar a estratégia, e um Conselho Nacional que ouve a sociedade civil, que é responsável por aconselhar o Primeiro-Ministro sobre as atividades e as ações que devem ser implementadas no âmbito desta estratégia. O próximo, por favor. Este slide é apenas para vos mostrar as várias áreas governativas que estão envolvidas no desenho e na implementação de uma estratégia de intervenção junto das pessoas que usam drogas, e que cobre não apenas as que usam drogas. Hoje todos os comportamentos aditivos e dependências estão envolvidos, e estas áreas governativas estão empenhadas em implementar a estratégia e desenvolver todo o trabalho nesta área. O próximo slide, por favor. Para fazer toda a intervenção, para trabalhar junto das comunidades, se olharem para o desenho de Portugal, que é um país pequeno, com 10 milhões de habitantes, vemos que temos uma distribuição por todo o território nacional de várias estruturas de resposta, quer em termos de tratamento, de redução de riscos e minimização de danos, de prevenção e de reinserção em todo o território nacional. Portanto, dar resposta a todos aqueles que precisam de intervenção terapêutica. Por outro lado, fazemos intervenção em ambulatório ou em termos de internamento, e sempre que aquilo que são as estruturas nacionais, verão aqui que nós temos um Serviço Nacional de Saúde gratuito para toda a comunidade. Sempre que esse Serviço Nacional não consegue dar resposta a todos os cidadãos, contratualizamos com entidades da sociedade civil que nos ajudam e que, no caso de comunidades terapêuticas, nos cedem camas para podermos tratar estes utentes. O próximo slide, por favor. De qualquer modo, o diagnóstico precoce e a intervenção nesta comunidade para as pessoas infectadas com o HIV era difícil, muito complicada, não por um lado, pela estigmatização desta comunidade, os utilizadores de droga, para além daqueles que eram infectados, mas tínhamos ainda outras dificuldades, que era a capacidade de fazer o diagnóstico, de o fazer de uma maneira rápida e a seguir ter capacidade para tratar, para cuidar, o que fazer com estas pessoas a quem conseguíamos fazer um diagnóstico. Então, em 2006, 2007, criámos este programa piloto, o próximo slide, por favor, que se baseava fundamentalmente num aconselhamento da população que usava drogas para poder fazer o diagnóstico, para poder fazer testes, a detecção tão precoce quanto possível da infecção e depois a capacidade de referenciar para tratamento. Não nos importava, não nos importa muito fazer um diagnóstico se não conseguirmos dar seguimento, dar acompanhamento a essas pessoas. O próximo slide, por favor. Para implementar este desenho, digamos, temos aqui um fluxograma que é confuso, eu diria, mas que de certo modo vos transmite também essa complexidade. A verdade, precisamos de fazer formação dos próprios profissionais que intervinham no terreno, naquela rede de intervenção terapêutica, fazer uma formação para todos eles, para que estivessem habilitados a fazer a intervenção, o aconselhamento junto das pessoas que usavam drogas. Fizemos testes rápidos a todos aqueles que consumiam, quer por via endovenosa e mesmo aos outros que consumiam que não fosse por via endovenosa, para tentarmos identificar tão precocemente quanto possível aqueles que eram seropositivos, depois do diagnóstico, um reforço de um pré-teste, diria um teste para confirmar que a infecção VIH ou que o teste era mesmo positivo, e depois aconselhamento e intervenção junto daqueles que eram positivos para os fazer, digamos, aderir a um programa terapêutico que depois eram referenciados para o nível hospitalar para poderem fazer essa intervenção terapêutica. Este programa foi desenvolvido num espaço temporal não muito longo, mas a intervenção com esta metodologia acabou por continuar a existir e ainda hoje faz parte do trabalho da intervenção junto dos nossos utentes. O próximo slide, por favor. De qualquer modo, mostrei-vos uma rede de tratamento, de intervenção estatal. De qualquer modo, há sempre comunidades mais pequenas, mais problemáticas, que precisam de uma intervenção muito mais específica. E como já ouvimos aos outros preletores anteriores a mim, é importante, é indispensável ter as comunidades locais a fazer diagnósticos, a propor soluções e a promoverem a intervenção e a implementação dessas soluções. É isto que fazemos neste plano operacional de respostas integradas. Localmente, a sociedade civil, as organizações da sociedade civil, os cidadãos são convidados a identificar o problema, a diagnosticar, a fazerem propostas de solução e depois o SICAD, a organização a que pertence, financiará os projetos para que a intervenção possa ser feita adequadamente. Próximo slide, por favor. Uma das intervenções que temos em prática é a redução de riscos e a minimização de danos, entre as quais temos programas de troca de seringas, programas de administração de metadona de baixo limiar de exigência e equipas móveis que fazem diagnóstico e detecção precoce das infecções, nomeadamente infecção por VIH. E com isso nós temos hoje, próximo slide por favor, resultados que nos parecem muito animadores. Por um lado, a percentagem da população consumidora de droga é muito menos, é 0,3%, dos que estão em tratamento apenas 16% são consumidores de heroína, dos que injetam são apenas agora 2% da população e a infecção VIH, apenas 3% são toxicodependentes. De todas as infecções, apenas 3% são toxicodependentes. Mostrava-vos, por último, próximo slide, por favor, aquilo que foi a evolução, penso que não precisa de... Próximo slide. Não precisa de grandes explicações. Esta foi a evolução ou é a evolução da infecção VIH em Portugal, nomeadamente nas pessoas que usam drogas. Penso que fala por si e é este o meu último slide. Muito obrigado pela vossa atenção. Próximo slide e fecha, por favor.
Thank you so much, Manuel Cardoso, for this excellent presentation, showing a case study how changes, both programmatic but also in the enabling environment, addressing the legal and structural barriers, has made a huge impact on actually reducing new HIV infections in Portugal, with over 90% reduction that we saw in this last slide. We'll now move to a community perspective, and we'll hear from Saro Imran from Pakistan and Yuri Yoursky from the Eurasian Coalition of Health, Rights, Gender and Sexual Diversity, providing a community perspective on organizing and collective action. Over to you, Saro, first, and then Yuri.
Hello, everyone. Thank you so much. So basically, I will go through the Trans Protection Act 2018 and its struggle, which is a very progressive bill in Pakistan. Next. Human rights violations and discrimination on the basis of gender identity is still very much a big issue in Pakistan, and there's a lot of discrimination and stigma attached with the transgender people, especially with the transgender women, and when it comes to health services too. Next. So the journey of the trans movement includes the major 3 events, that includes 2006 trans couple marriage case, to a trans man marry a cisgender woman in 2006, and that case got a lot of hype on the media as well as on the movement. And then in 2009 there was a mass protest by the 200 transgender women against the police department, which has humiliated them. And then in 2016 a trans woman shot 8 times, and she was still alive when she reached to the hospital, but the authorities refused to admit her because of her gender identity, and they were confused to either admit her in male or female ward, and in this duration of time she died. This actually boosted up the movement among the transgender community, and CBO's collective action, leadership of the community leaders as well as allies play an important role in the movement that actually lead up to the pass of Trans Protection Act 2018 in the parliament. Next. And that law includes, and that the best thing is that a transgender person shall have right to recognize as per the self-perceived gender identity, and there is no need of the medical checkup to be considered or to have a national identity card with transgender identity. Next. The law includes prohibition against discrimination in education, employment, healthcare, right to movement, and unfair treatment. Next. Prohibition against harassment. No transgender woman or transgender men should be harassed in any public place or private place, and it is actually a crime now to harass a transgender person in Pakistan. Next. Obligation of the government, and it is very important that it is the obligation of the government that includes protection, development of protection centers and safe houses, establish separate prisons, awareness of the public servants, vocational training, and small business to actually empower the transgender community economically and financially, so they can not be dependent on their abusers. Next. The right to inherit. There shall be no discrimination against transgender person in acquiring the rightful share of property as under the law of inheritance. A transgender woman will get the property, inherit property as per the rights of the women, and a transgender man will get the right as per the man. Next. Right to education, next. Right to employment, next. Right to vote, right to hold public office, next. Right to health. It's very important with the topic of this webinar that the review medical curriculum and improve research for doctors, because it's very important to review the curriculum that the medical students are going to in the medical universities and colleges in Pakistan, so that they can be aware of the needs of the health needs of the third gender, safe environment for transgender peoples in hospitals, medical and psychological gender corrective treatment. Next. The right to assembly. The transgender people can have a right to assembly and right to access to public places and right to property. Next. Guarantee of fundamental rights. Of course, apart from these rights that has been given in the Transport Act, a transgender person as a citizen of Pakistan is have the right of the fundamental rights, which are the given as per the UN Declaration of Human Rights, that are 30 basic human rights. Next. And what actually needs to be done now? Include transgender people in democratic spaces. This is not only for Pakistan, but also for the other countries, as a lesson learned for the movement of Pakistan and the success of the Transportation Act 2018, that the other countries should also include transgender people in democratic spaces, ensure economic justice, ensure universal declaration of human rights, self-perceived gender identity. And it's very important that there should not be a medical checkup for the transgender people, because it actually hurts their dignity. So there should be the concept of self-perceived gender identity, and then leadership platforms, and then legal identity. That includes the legal identity, national ID cards, and passport. So this was my presentation, and I actually believe that we need to have an equal resources and equal opportunities, especially when we talk about healthcare and HIV prevention. And I'm working for the HIV and AIDS prevention since 3 years. And what I have realized that it's very important to economically empower the key population to make a better choices. For example, safe sex practices, if we want to minimize the prevalence rate of HIV and AIDS among key population. Thank you so much.
Thank you so much, Saro. Over to you directly, Yuri.
Thank you so much. I hope you can hear me and you can see me. So hello everyone, my name is Yuri, Yoursky, and I represent regional organization ECOM working in Eastern Europe and Central Asia. We are community-led organization, and we are doing community organizing also in the region. So we have the members who are representing communities of gay men, trans people, and also the LGBT communities in general. One of our main areas of work is also to bring up to show this legal and human rights barriers existing in the region. One of our part of our work is we are producing the regional reports on rights violations to actually get this hard data that my previous colleague speakers mentioned that we need to have to advocate for these changes in the countries. Next slide, please. So here you might, I'm sorry for some noises. So you can see here that the data from last year showed that actually we collected 119 cases of rights violations related to right to health of gay men and trans people in Eastern Europe and Central Asia. And most of the cases actually, as you can see, actually, oh, sorry, I speak fast. Most of the cases are actually abuse of power by those who have in power, people in power, decision makers, or law enforcement bodies. And also the majority remains for the last 5 years is actually the medical workers who refuse to provide services or provide those services with discriminatory manner to gay men and trans people in Eastern Europe. Next slide, please. This showed that like the main perpetrators, as you can see from this analysis, these are medical workers or the police, which means that these target groups remains as a crucial one to work with, so that we would overcome existing human rights barriers on the ground. We're not speaking on the legislative level. We might change the laws, but on the ground, we need to keep working with the healthcare professionals and with the police, so that they would not abuse the power and they would not violate rights of our community. Next slide, please. These violations create this situation where communities of gay men and trans people, but I'm pretty much sure the communities of people who inject drugs and sex workers, with all the intersection communities, we have distrust in the system of the governmental system, which leads them not to trust the healthcare systems, and they would drop off from the HIV cascade. And that means that what we can see from the data in the region, that if we might be more or less good with the testing rates, but the second 95 are falling because people are falling from the treatment, because in the chain of providing services, they might face some homophobic, transphobic healthcare professionals, and they would not come back for their services again. Next slide, please. Another crucial data collection part of the work remains is the reliable data on the numbers of the HIV cascade of MSM and trans people in Eastern Europe and Central Asia, in all of your countries, because the numbers that our governments are providing, of course, they are diminished a little bit. Some of the countries where homosexuality is criminalized or highly stigmatized. In Eastern Europe and Central Asia, these numbers are low, or we don't have the data up to date. This is what UCOM does. We are updating all the time the relevant data on the numbers, size estimation of the populations, and the HIV rates among the communities. This all helps us to interpolate and to see how the numbers of the rights violation, the specific of rights violation, correlates with these numbers of HIV cascade in the region. Next slide, please. Another crucial issue at this stage is we are collecting the voices of the community, and this is crucial to understand what is a community organizing. We need to hear first of all from the community what they need, and for that we are doing this needs assessment. We might have specific needs assessment which been done, for example, in Uzbekistan for the first time ever, the needs assessment of gay men, because Uzbekistan is the country which still criminalizes homosexuality in the region. So we've seen what are the needs of the community in HIV prevention, what their needs in health services, what their needs in their rights. Also this year, we've collected this data on the needs assessment of young LGBT in the region to see where are the gaps and where our interventions can be the best to make them so. Next slide, please. Another crucial part is legal assessment. The first speaker mentioned them. I think it's very important that we do not forget that we need to see from the legislative point of view what are the legal barriers existing in the countries, and actually to compare them with international standards and to see where we need to put our advocacy efforts first from the legislative point of view, and then also from the practical point of view to see how to bring these changes. I wanted to show you the data from 2018. We are updating this next year. Next slide, please. So we will have up-to-date information. So this shows actually the numbers, the percentage of possibilities of the protections and the barriers for LGBT people in Eastern Europe and Central Asia, which are related somehow to sexual orientation, gender identity, and or to HIV issues. Therefore, you can see that the numbers, they are so far, especially on the scale of protection, they are really low. There is a lack of anti-discrimination legislation. There is a high numbers of HIV criminalizing laws in the countries. There is problems of migration with HIV in the region. There is a problems of access to HIV treatment for the migrant workers. There are problems of accessing HIV treatment because of the homophobic personnel, and all this and this data needs to be shown in the long-term run to be used in advocacy to show that the situation is not changing that fast as we wish. And therefore, I'm also glad that this year all the global strategies put in the forefront the human rights and the community up front, which I wish not to be on the list for all of us as the stakeholders, but really to be our guidelines so that the community should be in front. Please, next slide. So I wanted to show one positive case study, what can be good, as I was asked about, because some interventions are possible on behalf of the community organizations. So this is our case from Moldova in 2020. Next slide, please. We were collecting the cases of rights violations of LGBT people in the country for many years to see the statistics. Then we've complied them together with the data of the HIV cascade analysis related to gay men and also to trans women. And in January 2020, we've complied the report to the Committee of Elimination of Discrimination Against Women jointly with a local organization. And next slide, please. Then in Geneva, we've done all the related advocacy to specifically highlight that trans women are dropped off from the national HIV programs and they need to be specifically mentioned in there. And as a result, next slide, please. But later in March, the CEDAW provided the specific recommendation to include the transgender women in the national prevention and treatment programs on HIV/AIDS, which created this window of opportunities for the communities, and not only for the communities, but also for the engagement with the government and other stakeholders to include specific indicators of trans women in the national HIV program, so that they would enjoy the existence of the services specifically scaled up to their needs. Next slide, please. I wanted to finish, as I had a very little time, that's some highlights from this very short presentation. Once again, nothing about us without us. This is the very important principles for the UN agencies, for the governmental institutions, that we need to organize the collective group discussion and to collect the needs of the communities. We need to hear the voices of the community first before we start to create some programs. This should be crucial at my point of view. Second is collection of reliable strategic information. But that means that we might speak about community-led monitoring of implementation of national HIV programs or human rights violations as well. But also we need to speak about the collection of reliable data on HIV in the country, not those that our governments providing, which might still have some state-sponsored stigmatization of key populations. But we need to conduct this strategic data assessment analysis led by the communities. Third, human rights in the forefront of HIV programs. It's clear for everyone right now, without taking out the legal and human rights barriers, we would not be able to actually see the improving situation with HIV numbers in the region. And as you know, probably Eastern Europe and Central Asia remains one of the regions where the cases of new HIV infections are rising. And the last one, I think I want to mention it specifically at this meeting, is the strong and clear position and the commitment of UN agencies, WHO, Global Fund, and in front of the governments, the stakeholders, when providing national level funding, that if the government is dropping out one of the key population, I think it's impossible actually to develop any further dialogue, because when we provide the programs for some key population and some are dropped out, like can happen a lot of time in Eastern Europe and Central Asia, like gay men and trans people, I think we need to actually strengthen the position. I think you need to strengthen the position, dear agencies, if you hear me today. On this, I finish and will be happy to answer your questions. Thank you so much for invitation.
Thank you so much, Yuri, for this great overview on all the work that is going on in relation to addressing legal and structural barriers affecting access to HIV services, from assessment to all kinds of community-led actions in various countries in Eastern Europe. And before that, thanks again to Saro for this really transformational experience for transgender people and their rights in the context of Pakistan. So these are really inspiring examples that could show actually what is possible if we manage to bring governments, communities, and partners together to work towards changes. With that, we have a bit of time for discussion now, only very briefly, because we still have a few other colleagues who have prepared some specific reflections and commitments. I'd like to maybe quickly ask Carrie if we have any inputs from the Mentimeter as a tool or from the Q&A that we should address, and if any of the speaker would like to speak to any of the points in the Q&A, now would be the moment to get back to those. Carrie, over to you.
Thank you, Clemens. So we have not launched the Mentimeter. We'll do so after this if people want to share reflections. I see there are a number of questions in the Q&A box. It seems as though Saro might have dropped off, but I see a number of questions to Yuri. So maybe if I can just read them out, and we can ask other people to raise their hands should they wish to pose a question verbally. So the three questions for Yuri, the first one is, in relation to the needs assessment, are the virtual approaches used to reach communities or face-to-face engagements given preference? Then there is another question which says, Yuri, in your last slide, you did not see PEPFAR, and do you think they have a role too, along with the UN and the Global Fund? So perhaps we can start with those while other people raise their hands.
Thanks, Karen. Thanks for the question about the legal environment assessment. It's usually all the assessments are run by the community, and they are run, the data is collected by the community. It's assessed from 2 points of view. First is legal documents like the literature review and the comparison of those laws to international standards. Second, we do in-depth analysis of the practice. So we try to see how actually existing protection or not protection it correlates with the violations on the ground. So we try to show that not only the good laws are protecting, but that they might not most of the time work on the ground. I think this was first one, and the second one, I think I didn't get it, Gary, I'm sorry.
No problem. You had put some calls to action in your final slides, and you made specific mention of what you thought the UN agency should take up and the Global Fund. The question was whether you felt there were any specific calls to action for PEPFAR.
Yes, thanks. I think the specific call for action is, again, it's a funding, it's like by the Global Fund, and it's providing the national country level funding. So in specific countries like in our region, Uzbekistan or Tajikistan, when the governments are not accepting any funding to make HIV prevention or treatment for gay men because they're saying we don't have those, or the numbers are really low because of the existing laws. So it means that the position of this of the agencies when doing this negotiation should be very firm, that without having the proper programs for gay men and trans people, we cannot do this. Or second, it's a specific mention that how the legislation should change before the funding would come to the country. And in this case, we need to be very clear about the decriminalization of homosexuality. We need to speak about the protection from discrimination, the comprehensive anti-discrimination, which would include sexual orientation and gender identity. And we should speak also specifically, in case not only from my community, decriminalization of drug use. We need to speak about the decriminalization of HIV, which are a tough question, of course. But I think this should be very firm position when developing or reviewing the national applications for national grants within the Global Fund programs. I think this should be also the position of the WHO, UNDP agency, UNAIDS agencies that are working in specific countries where the legislation related to some key population, in our case, gay men and trans people, is still very bad. Thanks a lot.
Clemens, there's one additional question maybe I can just pose, and this may be relevant to all speakers. The question here is whether speakers could share their experience of addressing legal and structural barriers to key populations under the age of 18. So perhaps any of the panelists may wish to share any experiences.
Thanks, Carrie. Yes, please, any panelists who would like to share experiences here. Maybe also one more specific question we had for Saro here was what in Pakistan was the key to supporting this progressive legislation, and what advice would you have for other countries in conservative or stigmatized settings who wish to be more progressive and inclusive? So, okay, I see Saro may have dropped off, so we may actually have to see whether we can provide feedback to this response in writing. Are there any reflections on young key populations? We were actually planning, if I may say this in the meantime, to have a special session of this community of practice with key populations for young key populations, where issues relative to young key populations could be specifically addressed, and that session could happen sometime in 2022. So, Chair, that could be an opportunity to actually dig much deeper and have more detailed conversations. We had specific experiences this morning shared in the morning session by one of the speakers, but maybe Yuri or Simone would like to come in here.
Yeah, I raised hand. Don't want to overwhelm all the floor, but so about the young key populations. In this case, I think for HIV prevention is crucial. We need to look at the laws, because in many countries it remains that the oh my God, what's it in English? The HIV testing, which is done. Oh my God, I'm really bad with this word. So when you, on your own will, when the person can do the HIV testing, the legal age can start from 18. And I think it's really bad, and we need to advocate that we would have the possibility for own testing for the youngsters under 18, starting from 14 or 16. And it's very crucial, because nowadays it's a data which is approved by many data collection before, is that young generation now start to have sexual contacts or also drug experience very early. So we need to give them possibility to do the HIV testing earlier. Second, we need to speak about the age of the consent for sexual intercourse, which in some countries may still remain to be from 18 years old. And I think it's also wrong, because we need to take into account the reality that the young generation now is starting sexual life much earlier. And third, I think it's very important to mention is the right for legal gender recognition for trans people, which is also in some country might start not even from 18 years old, but from 21 years old. And we need to do the common actions actually to advocate that we are lowering the age, the possibility to change the gender earlier, because it's the right for dignity, the right for self-identification, which was mentioned by my colleague, and it starts not from 18 years old, it starts much earlier. And with that, we might see also the drop of HIV involvement in HIV programs, because there is no trust for medical system, which are actually violating some of the rights, and in this case, rights for self-determination. This is my contribution to this question.
Thank you so much, Yuri. Simone.
Just to highlight that we know that Angola as a country is working towards a provision on providing, like allowing young boys 14 and below, young people 14 and below of maturity to be able to get testing. So I think, but this is still in the work, but it would be great if it happens, and we would be sharing the this example once we finalize it. But it's great they are doing that.
Thank you so much, Simone, for this contribution. In the interest of time, we'll move on to the next slide and the next phase of this meeting, which is already getting to the final phase. And maybe before I hand over to Alexandrina and Jennifer and Andrew. A few words from Carrie about the Mentimeter link in the chat box that you can actually use to make contributions. Carrie.
Thank you, Clemens. Colleagues, we're about to paste a hyperlink in the chat box. All you need to do is click on it. It'll automatically bring up a screen. And please, we would welcome you to put your name and country and any of your further reflections or commitments coming out of this session as you hear the final reflections and also following on from the Q&A that we've just had. So it's just been put in the link. Please do so, and we will consolidate and also share other inputs along with the recording and presentations of this session. Thanks, Clemens.
Thanks so much, Carrie. And these commitments can be personal or organizational as you wish. This is not anything that's obviously legally or in any way binding in terms of a commitment. But we'd like to hear from you. What commitments, what ideas, what reflections do you take from these conversations, from these positive country examples in terms of changes that you can foresee or that you can imagine in your country context? And we'd be curious to collect those, and those could be discussion starters for seeing which kind of support is actually required in the specific country context. We come now to the final section of this meeting with reflections and commitments from specific partners. We have Alexandrina Iovita from the Global Fund. We have Jennifer Cole from the Office of the Global AIDS Coordinator of the US government, and we have Andrew Spieldener from MPACT speaking about their reflections and commitments in the area of addressing legal and structural barriers. Over to you, colleagues. Alexandrina.
Thank you so much, Clemens. I guess I'll go first. I represent the Global Fund, the Community Rights and Gender Department. We at the Global Fund very much align with all the commitments that you've heard about today. We also have heard time and again that stigma and discrimination and other human rights related barriers, the structural barriers that we've been talking about, interfere throughout the HIV response. They increase the likelihood of new HIV infections. They decrease the effectiveness of the responses. We've heard today very pertinent testimonies of how stigma and discrimination kills. This is the reason why we, the Global Fund, have asked our applicants to ensure that human rights interventions are part and parcel of all key populations programs. I've shared in the chat a number of links to our technical briefs. We've also been asking applicants to invest in programs to reduce human rights related barriers, specific programmatic interventions. And again, I've shared some of those links in the chat. These programs are based on the UNAIDS recommendations in terms of what are effective responses. These programs should be implemented across all the global partnership settings. These programs should be implemented in a comprehensive manner. It really should be a mutually reinforcing package of interventions, not just one-off trainings and meetings and roundtables, which seem to be the go-to interventions of many of our partners, regretfully, but which have not proven to be effective over time. We, the Global Fund, are holding ourselves accountable for how well we invest in such programs to reduce human rights-related barriers. We have a key performance indicator that looks at allotting 3% of our HIV allocation for human rights programs. In the previous funding cycle, 2017-2019, the overall level of investment has amounted to 120 million. In the current cycle, even though it's still work in progress, not all countries have submitted funding requests for the 2020-2022 cycle, but we've already attested the investment in an amount of over 174 million. So we do have a window of opportunity here, but investments and money are just inputs. So it's important for us to continue working together to ensure the implementation of such comprehensive and effective programs, to ensure that communities are really leading the response and have access to such resources. So we look forward to our continued engagement in making that happen. We have been working as part of a Breaking Down Barriers initiative in 20 countries to ensure that we have clear evidence in place on what are the barriers, what are the gaps in the response, and how can we address those barriers in a more comprehensive manner. We've supported multi-stakeholder processes. We've supported development of national strategic plans to address human rights-related barriers for comprehensive response. Some of the countries we've heard from today are part of this Breaking Down Barriers initiative. In those countries, we've seen a 7-fold increase in investment. The midterm assessments have shown that in each of these countries, we've had an increase in the scale and scope of programs since baseline. So having resources committed is really important, and it works, but having a continued effort and ensuring that the stakeholders are on board, that we're working across sectors, ensuring that communities have a platform to be able to meaningfully engage and lead is at least as important as the money. So moving forward, we look forward to working together to articulate the increased commitment to address stigma, discrimination, and other human rights barriers in our new Global Fund strategy. We look forward to ensuring that the most effective programs get funded, but we are able to also document what works well, document the lessons learned, and be able to improve the implementation science in terms of addressing stigma and discrimination. We're working very closely together with UNAIDS and other global partnership conveners, as well as with PEPFAR, for a more coordinated approach to funding such programs. We are also supporting community leadership and empowerment, including through a full adherence to the stigma index non-negotiables, ensuring that we have the relevant data to inform programs, but also that it's more than data, ensuring that communities are empowered to be able to produce and use such data. We're also committed to continue to support community-led monitoring, including monitoring of human rights violations. So not just community-led monitoring of availability, accessibility, acceptability, and quality of key population programs, but also integrating elements of documenting the human rights violations that do occur, ensuring that there are proper referrals to services, including legal services, ensuring that such human rights violations cases are actually followed through, and we don't just stop counting the data alone, but we actually focus on ensuring that there are responses in place. So in a nutshell, this is all contingent on us working together. We look forward to continuing our efforts. I will copy in the chat a link to the CRG Strategic Initiative Technical Assistance, and I encourage community-based organizations, civil society organizations that are part of this call to make use of that opportunity and request technical assistance in order to ensure that they are meaningfully engaged and consulted all throughout Global Fund processes. Thank you.
Thanks. Over to you, Jennifer.
Hi, good evening, good afternoon, and good morning, everyone. My name is Jennifer Cole, and I am the Technical Advisor for Key Populations in the Office of the Global AIDS Coordinator at the State Department. I'll be sharing some updates on behalf of the broader PEPFAR family at headquarters here in Washington, D.C., and for the United States. Key populations are among PEPFAR's core program and policy priorities going forward. Through PEPFAR's draft COP 2020 guidance and in alignment with new global AIDS strategy, we'll be deepening effort to support key populations through an increased focus on enabling environments that support KP-centered, differentiated HIV services. To this end, PEPFAR is prioritizing building KP competency of PEPFAR service providers, as well as highlighting the need to build leadership and service capacities of KP-led civil society organizations themselves. As referenced in the equity section of our draft PEPFAR COP guidance, the UNAIDS 2021 through 2026 Global AIDS Strategy recognizes that inequalities are central to the global delays and gaps in accomplishing the goals of HIV epidemic control. Therefore, addressing these inequities will be essential to success. Prominent inequities that impact global and PEPFAR progress are observed among key populations, children, and adolescent girls and young women. While PEPFAR has already dedicated attention and funding for HIV services in these groups, these investments have not been sufficient to scale and impact to achieve intended outcomes. We who work in key populations in PEPFAR often remind our colleagues that 65% of all new HIV infections in 2020 worldwide occur among key populations and their sexual partners. We need to do better to prevent these HIV infections. In using an equity lens to achieve HIV epidemic control for the long term, we must recognize that the public resources are inherently constrained and those limited fundings have to be supported to the most vulnerable and disadvantaged. We must explicitly ensure that donor and public spending is targeted preferentially where the needs are the greatest. PEPFAR country teams and national programs must take deliberate and specific action to identify and address those gaps in coverage for testing, treatment, and viral load suppression among subpopulations that are not meeting 95-95-95 benchmarks. In many of our supported countries, these gaps are among key populations. We here all know that members of key populations face a risk of HIV acquisition at many times higher than the general population. To close gaps for key population, the new PEPFAR COP22 guidance has updated program requirements to help achieve equity and impact for key populations. And just to note, our PEPFAR COP22 guidance will be released publicly on January 20th, 2022. Implementation of COP22 guidance will hopefully facilitate a more direct pathway to equitable services to all beneficiaries of PEPFAR dollars, most notably key populations. Thank you so much for your time.
Thanks so much, Jennifer. Andrew, as final speaker of the day, please.
Thank you. Hello, everybody. I'm Andrew Spieldener. I'm the Executive Director of MPACT, which is Global Action for Gay Health and Rights. I'm a gay man. I'm a person living with HIV. We know that HIV responses have been less successful in countries that criminalize same-sex sex work, and drug use. Criminalization of same-sex sex was associated with 11% lower knowledge of HIV status and 8% lower viral suppression levels. Sex work criminalization was associated with 10% lower knowledge of status and 6% lower viral suppression. Drug use criminalization was associated with 14% lower levels of both. Sure. Criminalizing all three key populations were associated with significantly worse outcomes ranging from 18% to 24%. I pulled that data from this article, which I'm putting in the chat. And I want to highlight some of the things that were said, just reflecting. Data. Yuri brought up data, and the reality is that for many of our key populations, countries don't admit we even exist. And we have to, as multilateral partners, as civil society actors, as government partners, potential partners, we have to do better at presenting the data, because if we're not presented as present, then countries have no reason to prioritize us. But Manuel, Saro, and Yuri all spoke about scale and nuance. And when we talk about scale, it's going to require both community, civil society partners, and government in order to make these structural changes. The good news is UNAIDS and the UN co-sponsors are very invested in making sure that these kinds of interventions are scalable. They want to be part of providing guidances and tools. And it's up to the governments to partner with community-based organizations and community-led groups in order to affect this change. When I talk about nuance, Saro brought up amazing narratives around what's actually involved in the Trans Protection Act and how many rights actually have to be enfolded in: the right to gather, the right to be able to hold office, the right to employment. These are all things that we need. So it's not just about protections, it's about what are the larger rights portfolio that we need in order to engage society. Policies and practices. So Yuri, Saro, and Manuel talked about policies and practices where decriminalization of drug use in Portugal, for instance, was the first step. And the next step was really creating community responsive treatment programs and other support services, recognizing that people who use drugs are people and part of the country. Yuri brought up the fact that even in places where there may be laws that on the ground, police and healthcare workers may actually be discriminating against key populations, and that there has to be an intervention done at that level. I wanted to highlight, Saro and Yuri brought out the brutality that we face as key population members. And just to point out that for many of us who are key population members, the same institutions that non-KP people take for granted, that they hold to keep them safe, actually brutalize us. And so I just want to highlight that some of the structures that are in place brutalize us. And both ask for interventions in those practices. Finally, intersectionality was brought up a few times, and intersectionality is about multiple kinds of marginalization and identity. And when we talk about intersectionality, we're looking at the full range of our communities. So a gay man who's living with HIV, a gay man who's using drugs, a gay man who's using drugs who's living with HIV. And so we have to look at how these multiple kinds of marginalization affect people. Some countries are good with one or two key populations. Some of them, really kind of lead with, we're good in harm reduction, or we're good in here, but we need to look at how we can advance that for all key populations. For instance, if you're a trans woman living with HIV who's also a sex worker, what matters most? The sex work laws, the criminalization of sex work is what's going to pull that woman into the law, into the police, which will cause her to be vulnerable to HIV criminalization laws and other punishments. So we really need to think and help countries understand the importance of looking at key populations as intersectional communities rather than just individual behaviors. Thank you.
Thank you, Andrew, for this brilliant reflection and summary, which will make the task of closing this meeting very, very easy. We actually have reached the end of our time, but we'd still like to take one moment to look at the Mentimeter and the thoughts that were shared in this context. So, Carrie, if you have a moment to do that, and if there are any reflections that came from participants in the Mentimeters, let's take 1 minute to look at them, and then we can close.
Thank you very much, Clemens, and thank you to everybody who has contributed. I see there have been 13 contributions through the Mentimeter. Perhaps we can take a second just to have a look at them. I think certainly a theme that's coming across is the importance of engaging key populations in the response, leaving nobody behind. There was a few comments recognizing specific success stories and asking for a bit more insight on the practicalities of how to apply that in other countries. That's certainly something that we will happily share with you, the case studies and also contact details if the speakers agree. Decriminalization remains one of the largest challenges and is something unsurprisingly that has come forth as an area of further commitment from each of the participants. Yeah, I think the note on young key populations certainly is something that we have recognized, and it's been put forward here as something worth further reflecting on. And I think that's something that the chairs of and the key partner group will take forward. Clemens, I think those are the main items so far that have been put forward. We'll keep this Menti link open should anyone wish to contribute further on gaps that they've identified or any further commitments they would like to share. So thanks so much.
Thanks so much, Carrie, and thanks to everybody for these great conversations linking structural barriers, legal barriers, and service access into really powerful conversation where we heard about transformational experiences, for example, from Pakistan, from Portugal, as Andrew has already summarized just now. We also heard a lot about practical steps in working towards addressing these barriers, from assessments to action, community led approaches, and I will not repeat them. I think they were all self-explanatory and very powerful. There's also a broad network of partners, as you see in this community of practice, including the South-to-South learning networks, where country-to-country experiences are shared. The Global Prevention Coalition, where we actually also have a lot of data and are showing it, where we have data on key population program responses on legal and structural barriers, and also a lot of gaps in data which are needed to actually inform programs. We haven't shown them in this meeting. We have done so before a few times. We can obviously at request share this data with you if you need them in your country-specific advocacy. So what is very clear, there is a great partnerships around this, around the global targets that member states have actually committed to, and there's room for a lot of action to happen in the next 4 to 5 years and when we're implementing this strategy. So let this not be the end of a conversation, but the starting point for a lot of new different ideas being taken forward and new collaborations emerging. We'll connect again in 2022 on the community of practice for key populations. We have additional sessions coming up on interesting aspects, including monitoring and evaluation and financing of programs, 2 other elements that closely link to the previous sessions, including this one on structural barriers and the other one we had on programmatic scaling up of key population responses earlier this year. With that, I wish you a great festive season towards the end of the year, and I hope many of you will get the chance to have a break and look forward to reconnecting in 2022. Have a great evening for today and a great time ahead. Thank you so much.
Thank you, Clemens. Bye.
Thank you, Clemens. Bye-bye.
Thank you.
Thanks so much, everybody.